Hi, my name is Partha Kar. I am a consultant in diabetes. I work in Portsmouth, and I've got two national roles. One is as the National Specialty Advisor for Diabetes with NHS England, and the other is as one of the co-leads of the Getting It Right First Time for Diabetes. So diabetes is one of the challenges, so to speak, in healthcare across the globe, and the UK is no different. We have a steadily growing prevalence of diabetes across the country. We have around 4 million people with diabetes, and amongst the diabetes, there are different types of diabetes. But in short, the bigger cohort is people with type 2 diabetes, which a majority of which is put down to lifestyle, health checks, etc. And the other broader type is type 1 diabetes, immune type, which means that you're pretty much born with it, or you have a immune response as a result of which you have that type of diabetes. Different other types also exist, such as genetic type, but in short, a healthcare issue which is all across the board and something that all healthcare systems, not just the NHS, see as challenges, whether it's in a hospital setting, community setting, or GP surgeries. So what we have with diabetes is the after effect of it. If so, over a prolonged period of time, if your control is not good, we're looking at issues. For example, problem with legs, problem with your kidneys, problem with your eyes, and in general, what we're talking about also reducing across the board your rate of having heart attacks and strokes. In short, anything which compromises your quality of life, and that's why it's important that we do get diabetes care right. As regards people living with diabetes, also at the very beginning, the diagnosis itself is going to be right, because that has an impact on the type of treatment and the care you receive. And then if you roll it out into people who go into hospitals for whatever reason, then it becomes an issue of making sure they're well looked after, their care is not compromised, and certainly there are no safety issues which come forward during the stay in hospital. So one of the fundamentals of when we look at improving anything within the system is data. And what we have done over the previous few years is the National Diabetes Inpatient Audit. And in simple terms, what we have looked at, where are the areas of safety in hospitals that we need to tackle? And that has consistently shown a few pictures. The next step of that was not just to take the data, but then to go into different hospitals across the country to see what were the challenges, not to say that they were getting things right or wrong, but more about what were the differential issues, or were there any common factors that we could target across the board that would help improve safety. And that sort of gave rise to a fair few points, particularly 4 areas that we felt would be the areas to tackle when we're looking at safety inside hospitals. So one of the areas that we picked up, especially when we were going around the country, was the huge variation in how you identify people with diabetes coming into the hospital. So the fundamental to trying and improving safety has to be for the specialist team to be aware that the person with diabetes has been admitted. So we went around hospitals which had an extremely slick system. They had an electronic system. The team knew in the morning who was admitted where, and the specialist team could dedicate their resources to the right place. Then we went into hospitals where it was done very much by paper, in the sense that people would be dependent on somebody else registering it and then letting other people know. Then we went into hospitals which had no system at all. So it was very much dependent on the ward team referring the patient on to the right people. And again, that is dependent on the workload every single team has. So one of the solutions, or one of the suggestions we have, is to learn from the good examples, is not starting anything from scratch. And clearly the areas which had a very robust system of using electronic means of identifying people with diabetes coming into hospital had better outcomes. So one of the recommendations was clearly to follow that good example and have electronic systems, which the NHS does provide. For example, background of diabetes is registered extremely well in GP surgeries, thereby linking that in with the admission and thereby making it aware to the local specialist team first thing in the morning. One of the other areas that we picked up and which was surprising, was the variation around having self-management policies. Even though this is a standard within NHS, we went to a significant number of trusts, which thereby they seem to not have the existence of anything to do with self-management as regards people with diabetes. Make a point. For example, if you were on insulin and you went into hospital, then they did not have a policy which said that if you were able and not in a state that you could not manage your own diabetes, you still didn't have control of your own care, which was a bit odd because people living with diabetes, if they're in the right state of mind, can manage their diabetes far better than a professional who has multiple other challenges on their plate. So this was a very simple initiative and also aligns a lot with what the NHS wants, which is, encouraging people to self-manage their own chronic disease in whatever setting. So again, some great examples from around the country, and what we have encouraged, as well as made it very clear that every hospital should have a self-management policy. The patient may choose to hand over their control to the clinician, but in general, the default should be that if they're well enough, the person with diabetes should be able to self-manage their own diabetes when they're in hospital. The third area that we looked at was around people going into hospital for surgery, whether it was emergency surgery or, more importantly, elective surgery. There seemed to be a lack of consistency around plans and policies in place. So hospitals which had a very clear policy about if you have diabetes, you come in at this point of time, this is your regime, this is what needs to happen. They had a much better outcome as regards length of stay, as regards lesser issues with safety, and patient experience being much better. So again, for sake of consistency, we have said that every hospital needs to have a very clear policy as regards anybody coming in with diabetes for any form of surgery. Now, bear in mind, this does not and should not have local variation. So what we do have at the present moment is NCPOD having very clear guidelines around perioperative care for people with diabetes. And recently, also on the back of it, the specialist organizations of diabetes and anesthesia, they've all got together and created a very similar work, which we encourage everybody to adopt. A consistent theme as regards a perioperative policy clearly leads to much better outcome for people with diabetes, and that's what we are strongly encouraging. So the final area that we looked at was errors. And across the NHS, even leaving diabetes aside for a moment, insulin errors is one of the highest errors in the system. And what we found, the variation there was not just the errors, but the lack of consistency about those delivering insulin and being aware of what challenges they will face when they're doing so. Insulin is an extremely useful and helpful medication to those who need it. It can be a quite dangerous drug in the wrong hands. So one of the basic principles we wanted to see that there was education for any carer giving insulin to anybody else. So as mentioned previously, self-management obviously being our cornerstone, but there will be many, many occasions in which case the carer has to decide on the insulin being given, how to give it. To facilitate that, we have encouraged that people do educate themselves, have education policies, and Leicester University have kindly come up with some modules which are available to the NHS, more importantly, for free. And thereby we have worked with them, it's in place, and we encourage all trusts to ensure that at least those who are delivering insulin, whether they're a doctor or a nurse or a pharmacist, they do have access to this module so they're aware of any pitfalls they might face when delivering this particular medication. So my message to anybody who's looking at improving safety for people living with diabetes inside the hospital is that the NHS is actually full of some fantastic examples. Not all of it needs investment, and simple measures like having self-management policies or free education portals, etc., that does help. Implementing perioperative policy, that makes a difference. And you can also go and learn from areas which have done really well. I would recommend you have a look at one of the Diabetes UK papers that's out there. You can have a look at the Getting It Right First Time paper, which is out there, which actually gives you good examples of care to look at. Phone them up, talk to them, same NHS, and they seem to have done much better compared to lots of other places. So that's certainly one thing. The other thing is that there has been existing investment from NHS England, specifically into helping more specialist nurses come in to help with diabetes safety. Please do liaise with your local systems, and because that is a commitment from NHS England in the long-term plan to ensure every hospital does have access to an inpatient diabetes team. So lots of initiatives in there, but no lack of good care. And I think my only message would be reach out to colleagues who are doing it and see what you can do. One of the things that is there or is coming through is after the National Diabetes Inpatient Audit that we have had over the last 5-6 years, we're now moving to a more tighter way of looking at harms, and that involves a National Diabetes Inpatient Harms Audit. And we'd encourage all trusts to be part of it, because at the end of the day, what we're trying to do is reduce these harms inside a hospital, whether it's causing of hypoglycemia or diabetic ketoacidosis. And I would encourage all of you to please be part of it, because that's what gives us the ammunition needed to make the case for increased investment or indeed help particular areas which are struggling. So please be part of it. And overall, that will surely help to improve safety within hospitals.